Thank you very much, Eric, for that introduction and bringing back fond memories of the doctor in Greenland. He did look like Max von Sydow, and it seemed to me that he was in a Bergman film contemplating God's silence rather than attending to my wrist. So it was a bit disconcerting, but it turned out okay. And thanks so much for all you've done, Eric, to make this wonderful program possible. Thanks to all of you for coming to what I'm sure will be an outstanding meeting. The topic is the person with the illness, and you heard Ted in his videotaped broadcast talk a bit about, let's see, is this going to work? Yeah. Oh, okay, good. Well, you know, I began this quote in my 2010 Vestermark lecture at the American Psychiatric Association, and Eric was there, and he asked me later if I would send him this quote. And I said, well, Eric, I'm not sure that this is the exact quote, because you hear many different variations. In fact, when Ted spoke this morning, I heard additional variations I hadn't heard before. So I did a bit of research, and it turns out that Osler actually stole this from Hippocrates. It's more important to know what sort of person has a disease than to know what sort of disease a person has. Now, one of my Spanish colleagues said, well, actually the way it's supposed to go is in Spanish, no hay enfermedades, sino enfermos, which is roughly translated, there aren't illnesses, only persons who are ill. So this seems to have taken on a life of its own. And then another colleague, Ronald Pies in New York, told me it was actually Maimonides, and he said the physician should not treat the disease but the patient who is suffering from it. Now, I'm beginning to doubt the value of searching on the internet for anything, and this quote captures it well. I think that was Winston Churchill, but I'm not absolutely sure. So let's begin with personalized medicine, which is really sweeping at least American medicine in a way that is somewhat disconcerting because the word person is in it. And it's a medical model that proposes that we customize treatment to the individual patient, so therefore it's personalized. It also denotes, however, the use of genomic information to personalize the approach, and it's created a huge backlash. In the eminent journal Science earlier this year, Horwitz et al. Made a scathing critique of it, and they said it should be called depersonalized medicine. They point out the movement's having exactly the opposite effect of what it intends. And they point out also that clinical, environmental, sociocultural features that are absolutely germane to the illness create a person with the illness that gets neglected within this model. They take, for example, cardiovascular disease, and they stress that one can not simply reduce this to one's genome, that there are dietary factors, behaviors like exercise, stress, culture, that may be far more relevant than the genome. And what they end by saying, what is needed to complement the power of genomics is an emphasis on personal attributes of patients and their environments. So we've been struggling with this since the days of Hippocrates, and we continue to struggle with it. And I think neural networks is a helpful way to start to integrate the genes and the expression of genes based on the environment. And this is a well-established scientific principle at this point, that our gene expression is going to be highly influenced by environment. We have experiences, and as we grow up, repetitive experience leads to the laying down of neural networks of self and other that basically become who we are in terms of our own self-image and the expectations that we have of how others are going to respond. And if your father screams at you and slaps you around as you grow up, you begin to think that with authority figures, you will be encountering somebody who's highly critical, who may haul off and hit you if necessary. And I remember a young man who came to see me who, while he never said it, he cowered in a way when he entered my office and sat down and related to me as though his major intent was to keep my criticism, or actually maybe even my physically striking him, at bay. And in fact, today, the way we would think about transference in contemporary discourse would be it's a matter of the brain doing a kind of pattern matching where we see how much this person is going to conform to the templates we have in the neural networks of self and other. So that certainly the genome is part of it, but it's very much influenced by our early experience. And the representation of people, objects, and situations in the brain are stored actually in the synapses. That is the matrix of connections. And of course, you've all heard the famous axiom that neurons that fire together wire together. Now, there's another important point here as we contemplate the person and personalized medicine, that personal identity does not necessarily overlap with genomic identity. We hear many reports in the media about two twins who were identical twins, separated at birth, and met up 35 years later. They had married women with the same name, they drove the same kind of car, they listened to the same kind of music, and these are great media stories. But people like Spector in the UK and others who've studied identical twins make the point that you rarely hear about the many, many sets of twins who aren't that similar, who have very distinct identities. One's right-handed, one's left-handed, one listens to classical music, the other listens to country music, and then we have one driving a Volkswagen and the other driving a Mercedes. And these, the fact that there is a different identity other than whatever the genome might dictate is very significant as we go on in trying to help us all understand the person. Now, psychiatric education has changed vastly. Decades ago, when I was a medical student and a psychiatric resident, we all read a book called The Person by Theodore Litz at Yale. I recently spoke at Yale, and I don't think anyone in the audience had heard of the book, so things have changed, and we no longer emphasize this. In fact, I had a course in psychiatric residency called Personology, but we don't hear much about that either. Now, the problem is we don't exactly know what the person is. I'm not sure that I do, but I'm going to take a try and tell you what I think the person might be from my perspective. First of all, I checked the Oxford English Dictionary. I thought the first definition was not particularly helpful, an individual human being. The second one was a little more helpful, the actual self or being of an individual. Now, let's look at that for a bit, because the self is a difficult construct as well, and the person is more than just the self as well, as we'll get on to. But let's start out with Hume, and Well, today we'll talk about some philosophers and some people in the mental health field and kind of put together where we might be going with the person. Hume, in 1888, who was very interested in such things, was quite dogmatic. He said, "When I enter most intimately into what I call myself, I always stumble on some particular perception or other of heat or cold, light or shade, love or hatred, pain or pleasure. I never catch myself at any time without a perception, and never can observe anything but the perception. If anyone upon serious and unprejudiced reflection thinks he has a different notion of himself, I must confess I can reason no longer with him." So that's a pretty firm and unequivocal statement about what he thought. Those of you who are James Joyce scholars will recognize this dilemma in Ulysses, where very much one of the things the book is about is trying to sort out the self in the context of all the perceptions going on. And this creates a problem in philosophy, of course, as the self as subject and object both. If we think of this statement, I think of myself, we have self as the phenomenal I of the philosopher, the I doing the thinking, and then we have self as a representation of who we think we might be. So we have this dilemma of how can the self be both subject and object, although we speak about it as though it is, and then can we think that the contents of consciousness are what constitute the self? That's complicated as well. With the help of Salvador Dali, we can look at memory, the cornerstone of self-continuity. Certainly, one way to look at the self is the collection of memories we have, the aggregate of personal memories and the social personas associated with them. The filmmaker Louis Buñuel goes so far as to say, the self is memory. The cortex is certainly wired by memories, so that we would think that all the neural networks laid down over the years of the self in action with others has something to do with it, but we'd also find that perhaps a bit reductionistic. So let's continue this pursuit of what is the self. There's a conscious self and there's an unconscious self, of course. Part of it is going to be hidden from us. Nagel, another philosopher, says, I may understand and be able to apply the term I to myself without knowing what I really am. Most of us don't know ourselves that well. Aspects of the self are repressed. They're split off, they're disavowed, and put into others often because they are unacceptable. The Hungarian feminist psychoanalyst Maria Torok says one way of looking at the Adam and Eve story is, as you recall, Eve is created from Adam's rib. And in the sense of the disavowed self, we could say men may disavow and project aspects of themselves that they don't like. So weakness and dependency is projected into women, while the man remains strong and can point to someone else who is weak and dependent, not me. This mechanism, of course, it goes on all of the time throughout life, and we have to acknowledge that we are masters of self-deception when it comes to figuring out who we are. One of my favorite bits of research that Drew Weston did at Emory was to ask middle-aged people to recall their college grades. Very few people got them accurate, but almost everyone who made mistakes made it in the direction of having better grades in memory than they actually had when they went to college. So we actually don't know ourselves very well, and that's a starting point in trying to understand the self. The problem with you is that you try to be a lot nicer than you really are. This is a familiar problem with our patients. and ourselves. The other issue here, I think, in self-definition would be that self is a multiplicity. It's not one thing. Galen Strawson, back to philosophy again, says there simply isn't any I or self that goes on through the waking day, even though there's obviously an I or self at any given time, so that we have a set of selves. And Stephen Mitchell, the psychoanalyst, once noted that a paradox of psychoanalytic work is that as patients learn to tolerate the multiple facets of the self, they begin to experience themselves as more coherent. This, of course, you see in the classic Hermann Hesse novel, Steppenwolf, where at the end the protagonist discovers that actually who he is a multifaceted self that is not easy to pin down to one thing. Buddha also has something to say about this. The self is only a conventional name given to a set of elements. Now, if we continue in this journey to find what the self is, we must acknowledge that it is certainly context dependent. Selves don't exist in isolation. Daniel Dennett said the selves are not independently existing soul pearls, but artifacts of the social processes that create us. And this includes, the fact that we will find ourselves behaving differently depending on who we are with and who the figures are and mean to us. We all see this in everyday life. We must integrate culture in this regard of context, because self-development is steeped in culture. And too often, I think we neglect this in our formulations about self. For example, the Asian novelist Gish Jen points out that Asian culture is not centered in self-experience, in contrast to much of Western culture. And she points out that there is an interdependent self created by this form of parenting that focuses much more on social context. And she says, as a novelist, it's very difficult for her to talk about self-experience in a Western way because of the Asian culture that she grew up in. And we must take this into account when we're trying to assess the various aspects of self in an evaluation of our patients. Now, a caveat that I'll repeat that I said earlier: the self is not the same thing as the person, so that in our pursuit of the person, we have to go beyond the self and look at the other. There's self as experienced versus self as observed by others. And we will be hard-pressed to answer this question: which is a more valid view of who you are? How you see yourself subjectively, or how others see you? A wonderful way to experiment with this is to watch people's reactions when they see themselves on videotape. Almost no one likes to see themselves on videotape, and myself included. And, we see ourselves on video, and then we turn to the person next to us and say, I don't look like that. And the other person says, oh, yes, you do. You do look like that. And then you say, my voice doesn't sound like that. And the other person says, yes, that's exactly how your voice sounds. And you said, no, I hear myself talk all the time. I don't sound like that. And so we get these kinds of reactions of, I don't look like that, my voice doesn't sound like that, ugh, I hate myself. Many people hate to see themselves on video. And, of course, the point here is that we really don't see ourselves the way others do. My wife, who's also a psychiatrist, her hobby is gardening. So she had a gardening magazine. One time I came home and there was a picture of a woman on the front of the gardening magazine with a gardening hat on. And so she said, who does that look like? And I looked at it and I said, nobody that I know. She says, yes, it does. It looks like me. I said, no, you don't look like that. She said, yes, I do. I look just like that. I said, no, you can't see yourself. She said, I see myself in the mirror. I do look like this. I said, no, you don't actually look like that. And by the way, I was right. I won the argument. So we don't see ourselves like others see us, no matter how hard we try. And this has to be factored into understanding the concept of the person. Now, this basset hound looks very sad, we will all agree. But if you were able to expand the slide, you would see that his tail is wagging. He's actually happy. So another principle is that from the outside, others cannot always see how we feel inside. And this is an irreducible fact of trying to identify who someone is. As clinicians, we have this problem all the time, that we think we know what's going on inside the person, and our empathy isn't necessarily perfectly attuned, and we're not mentalizing very well, and we may miss the boat because we're not tuning into what that person's internal experience is. We can't do that perfectly. So we would have to say, in our pursuit of some sense of who the person is, that knowing who the person is requires an integration of the inside and the outside perspective. And in fact, in psychotherapy, one of the principles of good dynamic therapy would be that the therapist must oscillate between empathic attunement, where you are right there with the subjective self of the patient, followed by a movement outside the self back to a more objective view, where you can help the patient see how he or she comes across to others. And then we oscillate from the subjective to the objective in the course of a treatment. Now, let's move at this point to some current problems in the field that are relevant to all of us. Let's start out with the loss of axis 2 in the DSM-5. And we would have to say, I think, that it has both positive and negative implications. One of the things that axis 2 did is it forced clinicians to at least consider dimensions of personality, with the idea they might otherwise completely ignore personality. But the way it turned out to a large extent was that the busy clinician could actually ignore axis 2 completely by writing deferred in an initial evaluation. And in going through many, many charts when I ran the Baylor Psychiatry Clinic, clearly deferred was the most common diagnosis on axis 2. And they said, well, someone else later can deal with that. Or in private practice, clinicians would say, insurance companies don't reimburse for this. There's no point to even bother with the axis 2 diagnosis. So it got rather disappointing in terms of the way it was meant to be used. Why was it created? Well, I got the answer to this question from the horse's mouth about in the late 1990s, Anthony Bateman and John Gunderson and I think maybe Peter Fonagy was on that symposium also. We were at the American Psychiatric Association, and we presented a personality disorders symposium. And we were quite critical of the DSM-4 model and quite critical of the use of axis 2. And afterwards, Robert Spitzer came up to the podium, and he talked to me for a minute. And you know, when he started with the DSM-3, he really had a great deal of power to kind of individually make decisions about what was going to happen in the diagnostic nomenclature. And he said, Glenn, I feel that you guys didn't really appreciate my efforts. And I said, well, what do you mean, Bob? And he said, well, the reason I included axis 2 is I wanted psychiatrists and other mental health clinicians who really valued psychotherapy to have a group of disorders that they could do psychotherapy with. And you guys are being very critical of that. I was a little bit astounded to hear that because the implication, of course, is that this is the classic mind-brain split, that axis 1 disorders don't need psychotherapy. They're just biological conditions that, need medication. And then personality disorders are purely in the realm of psychology and the mind and are not biological and therefore need psychotherapy in that kind of schism between mind and brain, when, of course, no one knows better than this group that there are extensive neurobiological findings in personality disorder research, and we also know that there are many psychological aspects that differentiate one major depression from another, and psychotherapy is very useful. But this is characteristic of the kind of split that we see in the field, and it was acted out to some degree with axis 1 versus axis 2. Now, here's another problem that I encountered as a professor running a clinic. The psychiatric resident would present a case to me, and it would be a major depression or maybe generalized anxiety disorder. And then the resident would say, I think the patient has some axis 2 stuff. Now, I quickly learned as a teacher that the translation of axis 2 stuff is the patient is obnoxious, difficult, angry, manipulative, or otherwise unpleasant. It never meant anything positive about the patient. Always that this was some sort of undesirable person that you'd rather not deal with. Now, here's some teaching notes for those of you who hear this. Axis 2 is not synonymous with being antisocial, demanding, unpleasant, or difficult. In fact, I used to tell the residents that some personality disorders, like OCPD, are diagnosable in people standing next to them in white coats on hospital rounds. Some of them may also be demanding, unpleasant, and difficult, but there are people with personality disorders who are not awful people, although this very much is the way that this has gone in terms of academic centers when you talk to trainees. Here's another aspect of this, is that the axis 2, axis 1 distinction may have raised awareness of personality disorders, but it unwittingly reduced axis 2 to a pejorative adjective in many, many places. Not just with trainees, but I would hear senior people talk in that way in the Department of Psychiatry. Now, one other point is relevant for all of us with the meeting title that Eric has selected. The person was often thrown into an axis 2 category as though the person with the illness is not relevant to axis 1. And that, of course, is very unfortunate. So another caveat is a personality disorder is not the same thing as the person. And we have to keep that in mind, too, that the person is far more pervasive than what we think of as a personality disorder. Who is the person? This is not an easy question to answer. Certainly, the person defies easy categorization. The person involves what is unique, idiosyncratic, a complex amalgam of multiple variables. And here are a few of the things that I would think are determinants of the person. And not that this list is complete. These are some that I would say are very prominent in my thinking as I go about evaluating and treating people. One, of course, is the subjective experience of oneself based on a unique historical narrative that's filtered through the lens of specific meanings. It's not just life experience, it's our interpretation of the meaning of that life experience. And then a set of conscious and unconscious conflicts. I put defenses in parentheses because we often know the conflicts by what defenses we're seeing. Representations and self-deceptions. This is a group of things we think are very much at the heart of who someone is. And a set of internalized interactions with others that are unconsciously reenacted and create impressions in others about you. In other words, your internal object relations, as they are played out every day. And, one of the greatest works of Freud was Remembering, Repeating, and Working Through, when he said that what the patient can't remember and tell you, he will show you by playing it out in front of you. And the fourth component is our physical characteristics. If you are beautiful or handsome, if you are 6 feet 8 inches tall, if you are 300 pounds, all of this will affect how you are seen by others and yourself. And your physical characteristics must be taken into account in trying to figure out who this person is. And then, of course, our brain, as a product of the genes in interaction with environmental forces and the creation of the set of neural networks by the cumulative experience we have. And then we'd have to say, as I said earlier, our cultural, religious, and social affiliations are going to be relevant as how they shape us. And in the cognitive domain, the cognitive style is certainly important, but we have to also keep in mind cognitive capacities. If you're intelligent, if you're only average intelligence, if you're below average intelligence, if you are brain injured, your cognitive capacities are tremendously affected, and therefore your sense of self. Now, let me just give a brief case example of how this might come together with the patient. Years ago, I treated a woman who was 35. She was married and had a 7-year-old boy and a 4-year-old boy, and she was a physical therapist. And she came to me because she had recurrent depression, chronic suicidality, a complete absence of sexual desire or experience, and a sense that something bad was going to happen all the time. As I got to know her, she told me that she had had incestuous sex with her father from the age of about 6 to the age of about 11. And when she started menstruating, the father stopped because he didn't want her to get pregnant. This, of course, is a horrible experience for her. And I said, "Did you talk to anyone?" And she said, "Well, I talked to the sister at the Catholic school in 2nd grade, and I told her what was happening. And she said, 'If you ever bring that up again, you will burn in hell. You must keep quiet about that.'" And of course, as you know, there's a substantial body of literature suggesting if you can process this early kind of trauma with another adult who can help you mentalize what's going on, there may be a better prognosis ultimately. In any case, she also said that she had never been able to experience sexual feelings or desire. And she said, in a sense, that she didn't know what people were talking about when they said they had sexual desire. She also became a long-distance runner, and she was competing in 10K races when she was in high school. And she tried to devote herself to her family, but always felt that something terrible was going to happen. Now let's start out with the impact of childhood sexual abuse and understanding something about her. You may have seen an article in the June American Journal of Psychiatry by Heim et al., where they had 51 subjects in a controlled study who they found that exposure to childhood sexual abuse specifically was associated with cortical thinning in the homunculus in the brain, where the genitals are represented in the primary somatosensory cortex, so that you would have a kind of neural plasticity operating in a child who was being sexually abused that protected the child at the time from the sensory processing of specific abuse experiences, but then contributed to deadening the sexual area as life went on, so that, in a sense, this patient was dead from the waist down, had no sexual experience whatsoever. And and became, in a way, a kind of ascetic who denied the need for pleasure. She would punish herself with long-distance runs, and much like the Anna Freud defense of asceticism, that she would say, I don't really need pleasure. Now, this developed into this identity as this self-disciplined long-distance runner who had this stoic attitude about self-punishment. And what we might say from a psychodynamic perspective is that there was a deficit structure there, clearly with the cortical thinning in the brain, but this deficit structure then became conflictual as she grew old and tried to adapt to this. And she also told me in one of the therapy sessions that she wanted to become a runner so she could never be trapped again. She could always find a way out. She could get away. She was very much devoted to her boys, her job. She said her husband was a loving man, and she went through sex to please him, but had no reaction at all to it, and just kind of went through the motions. She also had a conviction that she was thoroughly bad. She would say this frequently in the therapy, and as we went on, she had an enormous reservoir of rage, both at dad and mom. As you know from those of you who've studied childhood sexual abuse, often the rage is even more intense at the mother than the father in these cases. But in her case, she was furious at both of them for doing nothing, and of course the rage got redirected towards the self. And then we also see in this case, another determinant I covered in my list, the religious cultural factors. And of course I realize that all Catholic schools are not like this. In her case, this nun that she talked to and confided in turned out to be a powerful force in her mind, which told her that she was bad and she might very well burn in hell if she didn't keep her mouth shut. She lived with this expectation that lightning would strike at any moment, and you frequently see this with people who've had severe childhood sexual abuse or other kinds of abuse. The idea is you don't dare feel good or have a positive expectation because something horrible will happen if you do. And I didn't mention this, but when the first time she came in, I'm looking at the interpersonal distance on the slide. Most people, if I were sitting at my desk, most people would sit about where that table is. But she chose a seat way on the opposite side of the room on a couch. And I said, are you okay sitting there? And she said, yeah, I'm fine sitting over here. And she said, the Hopi Indians have a saying that everyone finds the best place to sit when they walk into the room, meaning that for her, the best place to sit was considerably away from me for her own protection, I assume. Now, she also had a tenacious clinging to suicidality as a kind of escape hatch from her intolerable situation. One of the things she told me was that when she was being abused by her father, she would have the subjective experience of depersonalizing and floating up towards the ceiling. And she would look down and say, that's happening to someone else, not to me. So this kind of depersonalizing or dissociating defense. And then she had the fantasy that an angel would come down from heaven and take her hand and pull her up to heaven. So she said, I thought about suicide a lot because I knew I was not trapped. And she said actually that this had gotten her through many difficult moments in her life. And I'm reminded, of course, of the famous Nietzsche quote, which goes something like, the thought of suicide has gotten me through many a difficult night. And this is how she felt as well. Now, what are the treatment implications of what we're talking about with this model of the person? First of all, as everyone, including Ted has said, and Eric, we don't treat disorders in isolation. We treat a person with a disorder. The person of the therapist must also be taken into account. We can't take ourselves out of the equation. Treatment is not simply a series of procedures. A person is doing the treatment. Jonathan Shedler made a witty comment about that. He said, it's more important to know what sort of person treats a condition than to know what sort of treatment manual the person is following. And there's some data on this that Sid Blatt collected from his re-examination of the NIMH Collaborative Research Project on Depression. And Sid noted there's little attention paid to the person of the therapist in therapy research. And in the study, the NIMH study, he identified a subgroup of therapists who had better outcomes consistently than the other subgroup, and said these characteristics could actually be identified. Now, one of the things we know from a lot of research is that the therapeutic relationship appears to be far more important than a specific technique in predicting outcome. And this itself means that we need to be looking at what certain therapists do that facilitate the process. Krupnik looked at the NIMH project also, and this has been some years ago now, but she noted the therapeutic alliance accounted for more variance in outcome than any of the treatments themselves, CBT, IPT, imipramine, or placebo. Now, one of the meanings of this, of course, is that you can line up 10 psychiatrists and they're all prescribing the same medication or the same placebo, and yet they're getting different results based on the therapeutic alliance. It shouldn't really be a surprise, but it shows the complexity of treatment. There's also quite a bit of an interest recently in therapist effects, notably in Stiles writing, that even in an RCT where there's a manualized approach, that there is what's called appropriate responsiveness, so that there's a flexible shifting of approach based on how the patient is responding, and most manuals take this into account in some way. But it's hard to identify which particular intervention creates which effect in psychotherapy research because of the way this person is shifting. And what I remember when I was working at the Menninger Clinic, one of the wise old men there was Leonard Horwitz, who had been involved in the Menninger Psychotherapy Research Project. And he made a point that when they looked at all the therapists, that flexibility was the quality in therapists that led to the best outcomes. Rigidity was the quality that led to the worst outcomes. And he said they couldn't publish that because the therapists identified as rigid would know who they were, so it never got published. Now, why is the person being ignored and neglected in contemporary psychiatry? There are many reasons for this, but just a few of them quickly before we stop. We all hate complexity. We like things nice and simple, you know, and it gets messy when you start to try to factor in the person. It's much easier to categorize people in ways that we all do. We prefer simple reductive thinking. I remember the eminent neurologist Antonio Damasio saying that it bothered him the way journalists were always showing brain scans in the New York Times science section and saying, no, that location is where sex is, and this location is hunger, and this location is whatever. And they would have this kind of reductive process going on. And he said every time he was interviewed, he tried to explain to the journalists that, in fact, there was a distribution of functions in the brain, that you can't pinpoint something in a simplistic way like that, but we certainly want to read that in the paper to make ourselves think everything is going to be simple and easy. Getting to know the person takes time, and time is money. This is a huge problem, as you all know, and psychiatry in the United States is often reduced to a 10-minute med check, and some psychiatrists I know will not want to hear about what the patient is saying except for the side effects. Getting to know the person may be unsettling to the clinician. We may not want to know details. We may want to get someone in and out. The classic thing I have trouble getting psychiatric residents to do is really get into suicidality. What they like to do is, any suicidal ideation? No, good, all right? Now, any sleep problems? And I say, no, you got to slow down there. Look for the eye contact, look for the nonverbal information. And they don't want to know if someone is suicidal, and many of them will say if they're suicidal, it's going to throw off my schedule and I've got to get all involved and to get them in the hospital, etc. Technology is a problem too. You know, we now have so many people complain they go to see the doctor, and the doctor is not making eye contact but is typing in the electronic medical record, and don't bother me with too much information because I'm trying to type it all. And frankly, in many places, the electronic medical record seems more important than the patient. And many, many clinicians complain of that. So now, what can we do about all this? Well, this is not an easy problem to solve because let's face it, if Hippocrates and Maimonides were complaining about it way back then, it's been a problem for a long time. And we can make little efforts like trying to bring the person back. It's certainly a way of thinking to try to find out what's unique, what's idiosyncratic about this person, how do they experience their illness. Certainly, we can let the patient tell his or her story. There was this shocking, not so shocking, but disconcerting article in the Journal of the American Medical Association where they tape-recorded primary care practitioners at work. The average primary care doctor interrupted the patient who was telling his story in 18 seconds and started asking specific questions because there wasn't time to listen to the person's narrative. Nonverbal behavior tells you so much, even when the patient doesn't have time to tell you their story. And I think it's important to have a certain kind of humility that the patient supervises us. We need to listen to the patient. We need to shift according to what the patient is telling us and pay attention when we're missing the boat. And finally, we get back to Kraepelin here again. The affective and schizophrenic forms of mental illness do not represent the expression of particular pathological processes, but rather indicate the areas of our personality in which these processes unfold. So this problem goes way back and has been something that the greatest figures in the history of our field have contemplated, and I'm not sure that we can find brilliant answers that they miss, but I think we should all be striving in that direction. Thank you very much.